Good morning, everyone. I hope everyone is doing fine. Today, I'm going to talk about pleural fluid, that what is pleural fluid and how to examine pleural fluid. What are the disease which we can indicate like when we get this example. So we are going to talk about the depth of pleural fluid. So the subject is 5003 and the course name is Medical Lab Technology. Let's start with pleural fluid. So that's how the basic structure of a lung, which looks like it's a double lobe, which is having a two layer, visceral layer and the parietal layer. So you can see the outermost layer is the parietal layer and the visceral layer is the innermost layer, which is denoted by blue color, and the outer layer, which is a parietal layer, it is denoted by red color. And the space between this red and the blue, that's mean the space between the visceral layer and the parietal layer, in between, it is known as the pleural cavity. So cavity means a hollow space. So that's mean in between these two layers there is a hollow space which is known as a pleural cavity. And in this pleural cavity, in this hollow space, we can say that there is a pleural fluid which is present. So you should know where the, if you're talking about a fluid, where the the fluid is. So the fluid is present in the pleural cavity, and the cavity is between the parietal layer and the visceral layer. So let's talk more about pleural fluid. Pleural fluid is a fluid that is found between the layer of the pleura, that membranes that the line of the thoracic cavity and surround the lung. So as we discussed that it is between the visceral and the parietal layer, it is covered for the thoracic cavity. The space containing the fluid is referred to the pleural cavity as we discussed. The normal pleural fluid consists of a small amount of a thin fluid that functions as a lubricant during breathing. So the very function of a pleural fluid is that it helps as a lubricant. It makes the viscous fluidity. It helps in lubrication. An excess amount of pleural fluid can be caused by many conditions and is known as pleural effusion. So when there is an excess, when there is a normal amount of pleura, it is good. But when the amount exceeds, it is known as pleural effusion. Some common cause of pleural effusion could be heart failure, pneumonia, and autoimmune diseases such as rheumatoid arthritis. So when you can see this pleural effusion, you can see during the case of heart failure, during the autoimmune diseases like rheumatoid arthritis, pneumonia. In this case, what happened? The normal range of pleural fluid, which is there in the cavity, it exceeds the normal range, and that's how we say it's pleural effusion. So if doctor finds that the patient have too much pleural fluid, he may recommend that a sample of the fluid be removed from a procedure called thoracentesis. So the procedure, how we collect this pleural fluid from this pleural cavity, the procedure of collection of pleural fluid is known as thoracentesis and sent for analysis to help determine the cause. So we will be examining that why there is excess pleural fluid, what is there in the pleural cavity, what is the abnormality. We'll just examine the pleural fluid. With lung cancer and excessive amount of pleural fluid, it is quite common and can be either benign or due to the spread of lung cancer cells into the pleural cavity. Whatever it could be a case, whenever we are examining the pleural cavity, it could be the fluid is excess, or it could be some benign cells are there, or it could be some unwanted materials are there, like cells are there. So that's how when we examine, we'll get to know why the reason behind this pleural effusion is the one. So let's talk about more pleural effusion. So pleural effusion is a collection of fluid in the pleural space, is a rarely a primary disease process, but it is usually secondary to other disease. The pleural space normally contain 10 to 20 ml of serous fluid. So that means the pleural which is present in that pleural cavity, it's 10 to 20 ml. So when there will be a pleural effusion, that means it will be more than 20 ml. So the normal is 10 to 20. But when we are denoting a word pleural effusion, that means it is exceeding more than 20. Any condition that interfere with the either secretion or drainage of the fluid leads to pleural effusion. Pleural effusion is a collection of abnormal amount of fluid in the pleural space. So let's do the classification. When we are saying a pleural effusion, there could be a two type of reasons why the pleural fluid is excessive. The one is a transportative and another one is a exudative. So when there is a high level of pleura in the pleural cavity, it could be two reasons. The one is a transudative and another one is a exudative, and that's how the classification we do. So let's talk about one by one. So let's just talk about what is transmutative effusion. So transmutative effusion, also known as hydrothoracis, occur primarily in non-inflammatory condition, is an accumulation of low protein called low cell count fluid. An imbalance between the pressure within the blood vessels and the amount of protein in blood can result in accumulation of fluid. Transudates are most frequently caused by congestive heart failure or cirrhosis. If the fluid is determined to be a transudate, then usually no more tests on the fluid are necessary. So what it does mean? Transudative, when we are talking about a transudative effusion, it could be the condition because of non-inflammatory conditions like low protein. There may be a low protein, or there is a pressure within the blood vessels. Because of that, the pleural effusion is there. Because of that, the level of pleural fluid is high. Why? Because of any condition which is non-inflammatory, such as the pressure is very high, in the blood vessel, or it could be because very low proteins are there in the blood, and that's the reason it calls a transudative effusion. Now, what are the cause of transudative effusion we are going to talk about? As I said, the pressure increase, the hydrostatic pressure increase and the oncoparetic pressure decrease, unable to remain the fluid within the intravascular, fluid shift interstitial space and effusion. So what happens when there is a low protein in there in your body and the hydrostatic pressure is very increased, that cause a high level of to form or a form accumulation of fluid to be there. So that's how the effusion increase. Now let's talk about the another case, which is exudative effusion. What is exudative effusion? So as we talked that the transudative is non-inflammatory, here the exudative is just opposite. So here exudative effusion will be only when there will be some inflammatory diseases. So injury or inflammation of the pleura may cause abnormal collection of fluid called exudate. If the fluid is exudate, then additional testing is often ordered. So exudates are associated with a variety of conditions, diseases like virus, bacteria, fungi. So whenever there will be bacteria, so it could be any infection because of virus, bacteria, fungi. Infection may originate in the pleura or spread through from the other place in the body. So whenever we are talking about exudate, the extra fluid which is coming over there. So whenever there is an increase, it is because of virus, bacteria, or fungi. Whereas in transudative, there is because of a pressure. Here we are saying the exudative effusion is because of the excessive bacteria, fungi, or because of some microorganism are there. Whereas in transudative, there was the because of non-inflammatory reason. Here the exudative effusion is because of the inflammatory reason or because of some microorganism. Like bleeding disorders, pulmonary embolism or trauma can lead to a blood in the pleural diseases. So in transudative, basically there is no further testing we have to perform, whereas in exudative we have to perform the further testing in order to check which kind of a microorganism are there, which kind of a bacteria it is there. So the further investigation is required. So inflammatory conditions such as lung diseases, chronic lung inflammation, for example, due to prolonged exposure of a large amounts of asbestos, sarcoidosis or autoimmune disorders such as rheumatoid arthritis, systematic lupus erythematosus, all are the reasons which can influence this exudative effusion. Now we'll talk about the diagnostic evaluation. What are the first ways to diagnose this? So very first thing is the chest X-ray and the ultrasound detects of this present thoracentesis. As I said, the thoracentesis is a way of collecting a pleural fluid. So by performing this procedure of thoracentesis, we'll be collecting this pleural fluid, and that's how we'll be diagnosing it. A macroscopic examination and then a microscopic examination will be there. Now, how to prepare patient for the test. This is very important. When we are taking a collection of a patient, we have to make sure the patient is properly aware, is in the right position, is in the right way, so that we can collect the sample. So patient should be directed to sit on the edge of a chair or on the bed with his head and arm resting on a table. Clean the skin around the insertion site and drape the area. So make sure whenever you are collecting the sample, you have to make sure the area from where you are collecting, it should be clean enough, because if it's not clean enough, what happens, the residing microorganism will be participating in the sample, and that's how it will be giving you a false result in that. So that's how we have to do. So we have to make sure whenever we are doing the collection, we have to make sure that we are cleaning the site location of it. A local pain-killing medicine like anesthesia is injected into the skin, which stings a bit but only for a few seconds. So we have to make sure if it is we are giving a little bit of anesthesia so that it won't it won't give a big pain to that patient. As fluid drain into a collection bottle, many people cough a bit as the lung re-expands to fill the space where the fluid had been. The sensation normally lasts for a few hours and after the test is completed. So we have to make sure the patient is very comfortable, because of course it is an invasive procedure and there will be a little bit of pain. That's the reason we are doing for going with the anesthesia. So we have to make sure that we are calming the patient, we are making the patient to breathe in, breathe out properly so that there won't be any interruption. So this is the prescribed location, this is the prescribed position we ask for the patient to sit, and that's how you can see that that's how the patient will be sitting, and that's how we will be doing the thoracentesis. So this is a preferable position in order to collect the pleural fluid. What are the risks involved in thoracentesis? So, as I said, that it is a very invasive procedure. We have to collect this pleural fluid from this pleural cavity, which is deep into the thoracic cavity. And so, what are the risks one can have after thoracentesis? Like collapse of the lung, like excessive loss of blood, fluid reaccumulation, infection, pulmonary edema, respiratory distress, and fainting. These are some common and the more general symptoms after thoracentesis, or while doing thoracentesis you can face this. So make sure you are doing the collection properly and more efficiently. Well, transudate fluid and the test result. What are the results we can have? Transudates are most often caused by either congestive heart failure or cirrhosis, as we already discussed. Typical fluid analysis results include physical characteristics like how we are doing the fluid is normally a clear solution. It's a transparent solution. So you can also do that once you collect the sample, you can physically see, you can physically examine that. Okay, yes, it is transparent color or not, or it is having any clotting or not. So that's how you can do the physical examination. Protein, albumin or LDH level, low cell count, or few cells are present. So you can do the further testing like this. Now, in case of exudate fluid, now exudate can be caused by a variety of conditions. So that's the reason it's require further testing. Uh, Physical characteristics, of course, again we'll see that it is white in color, transparent in color or not. Then we again will go some basic tests like protein, albumin or LDH. Then we'll do a chemical test like a protein and albumin may include some glucose test, lactate test, any further test we'll be doing it. So that's how about the pleural fluid, and these are some references which you can go through, and that will give you more depth about this topic. I hope you clear this topic, and by doing this you know what is the difference between transudative, and you know the difference between exudative, and you know what do you mean by thoracentesis. I hope you like the video. Thank you so much and have a great day.